Good evening, ladies and gentlemen. Welcome to Learn from the Legends, the international bi-monthly webinar series organized by FNNF Kerala and IAP Neonatology chapter. It's indeed an honor to have Dr. Arun Nair from Auckland University, who will speak to us on evidence-based neonatal care bundles in the NICU. It's my pleasure to introduce the eminent moderators of the day, Dr. Geeta Gatwala, Senior Professor and HOD of Pediatrics, PGIMS Rohtak, and Dr. Prashant Karia, Secretary, Gujarat NNF Chapter, and Assistant Professor, Government Medical College, Surat. Now, to introduce the legend of the day, Dr. Arun Nair, I invite Dr. V.C. Manoj, the organizing chairman of Neocon 2022, the great event at Thrissur in the last week of May 2022. Over to Manoj to introduce the eminent faculty.
Thank you, sir. Hello, everyone. Isn't it time we did a reality check and discuss the outcomes in our NICUs? If you do that, it's going to be an eye-opener. We all know neonatal environment is changing and quality improvement has taken over as the most important initiative to improve neonatal care. Is Care Bundle the best quality initiative in various conditions that we toil in our NICU? Well, ladies and gentlemen, to discuss this very relevant subject, we have a true legend who has done some original work in this field, Dr. Arun Nair. Dr. Arun Nair is a very senior consultant neonatal pediatrician who now works at Waikato Hospital, Hamilton, New Zealand. He holds dual citizenship of India and New Zealand. He is a medical teacher in pediatrics and neonatal medicine during the various positions that he held since 1983. He has special interest in research and quality improvement initiative projects that has been involved with various research projects right from the beginning of his career as a pediatrician and neonatologist. Most of these research activities have resulted in publications as well. The list is too big for me to enumerate here. I will just mention some of the relevant ones. Forgive me, sir, for missing out the other ones. The child study, the provide study, the parent study, the 3D IMPS, then some of the, he has helped the industry in developing some of the products like for Fisher and Paykel, the infant nasal cannula production evaluation trial, infant CPAP interface production evaluation trial, etc. Then COSI2 trial, use of pharmacy grade coconut oil for topical application to prevent late onset sepsis in preterm babies, aviation study, multivitamin levels in very low birth weight babies, etc. He is also a peer reviewer of several international academic journals as well as for various years. Now, that is not the reason why he is here. He is here because we thought we have been in our series, the Learn from the Legends, all the way having talks by true legends on the various aspects. Now it's time for us to actually introspect. And this legend, Dr. Arun Nair, has developed 3 bundles of care documents which have helped successfully reduce morbidity significantly, probably the most significant reduction reported in NICU. The CVL related sepsis bundle in 2010, ELBW care bundle for IVH in 2018 and NEC bundle in 2019. And now he is going to talk to us about his work. So I would not stand between you and the legend Dr. Arun Nair. Over to you, Dr. Arun. So you're muted. Yeah, you're muted again. Please unmute. Please unmute, sir. You're muted.
Am I okay?
Yeah, yes.
Are you able to hear me?
Yes, you are. Perfect.
Okay, can I get my presentation now? Or do I need to share?
You have it open in the desktop, sir?
Yeah.
Just share the button, no? What we are just right now, same thing. Yeah.
You able to hear? See?
Yes. Perfect.
Right. First of all, good evening to everybody. Dr. Geeta, Dr. Ravi, Dr. Prashant, to Dr. Manoj, and the rest of all my friends and colleagues from all over the world who probably are watching. I hope so. It is actually very early morning for me here. Actually, it's about 2 o'clock in the morning. So halfway through, I might even sleep off. Just wake me up if that happens. I'm just kidding. Okay, I'm quite awake, and I'm just we're looking forward to this. At the outset, let me thank Manoj and the organizers of this wonderful forum. I have been watching many of those presentations ever since it has been put into practice. And I have seen and heard some of the very high quality presentations. So obviously I'm quite honored to be asked to present today. And I must admit that it is the perseverance of Dr. Manoj who kept reminding me that this is one of the things that he wants me to do. So despite early hours of morning, I thought this is worthy of talking. So I looked at all the topics that has been discussed. He said, you can choose a topic of your choice. And there were many, as you can say, in many of those areas. I have some interest as well. I could have spoken, but I thought of late, I have had some obsession with this area of quality development in the newborn unit. So I thought that would be an appropriate topic to go ahead with. I hope people will enjoy. I'm sure it's not a new thing for many of the people who are listening today. So what I have done is I have broken some of these things into sections, and I put some pictures from New Zealand. Every time I speak in India or somewhere, people always ask me, how does it look? It's a beautiful place indeed. So in and around my hospital, I got some few pictures I will show you. I should tell you that I work as a neonatologist at a hospital called Waikato at Hamilton, but also I'm a senior clinical lecturer in pediatrics and neonatal medicine for College of Medicine. And also I'm associate with the Liggins Institute. Some of you may have heard about it in New Zealand. So this is the overview of my talk today. I'll talk a little bit of my perspective of evidence and something about decision-making, evidence-based practice itself, and something new called the implementation research. Many of you may have heard about it, but it's something that's coming in the area of research. Care bundles, the topic of today, some definitions in the processes, and I will talk about some evidence of the care bundles as well, and some literature on the neonatal care bundles, which are just appearing in the journals. And I will wind it up with an example of the process from our center with a summary. Talking about legends, Sir Robert Hutchison, all of you must have, in one way or the other, been influenced by Professor Sir Robert Hutchison's work. I have, when I was a medical student, we used to have the handbook of clinical medicine from Hutchison. We used to read about it. He actually came out with a physician prayer, and I thought, as is traditional in India, always we start something with a prayer. I would like to read aloud this prayer, and it is very, very appropriate for this presentation. So that is, from inability to let well alone, from too much zeal for the new and the contempt for what is old, from putting knowledge before wisdom, science before art, and cleverness before common sense, from treating patients as cases, and for making the cure of the disease more grievous than the endurance of the same, good Lord delivers. I think this is very appropriate for this topic as well as for the practice that we are involved. So moving on to evidence, this is a view from my office in the hospital. It's a beautiful place. Let's move on. Evidence. Evidence cannot be blindly used without taking the setting where the evidence comes from into account. This has been brought about very clearly in the recent research work by Sudhin and colleagues. You must have seen that you can't just borrow things that is happening in one setting and apply it to your setting. I have been involved with, and I have done some work on IVH and the prevention of IVH with indomethacin when I was in Muscat with Prakash and all the other group for people who are active in this forum. And what we found that it actually increases instead of preventing in a setting of that type. And so I thought, and I learned from that yeah, long time ago, we can't be blindly taking evidence from one setting and using it for another setting. Evidence of benefit is only an aggregate of all the responses in a population. This is something I keep on telling my residents and junior colleagues. Evidence, the way that we are generating at this point of time, is basically based on studies on a population. And what we get is an aggregate response in a population. So if an intervention is making a difference in a population, it automatically doesn't mean that it will apply to the individual patient that is in front of you. It gives you only a probability. Because, as I said, it's an aggregate response. So what happens is in that group of people, there may be some who have not benefited. There may be some who have had an adverse reaction. But sum and total of everything together, it is shown that in that population is better off than in the control population. So that's something basic, but you need to keep that in the back of your mind. What about some evidence is better than no evidence? As you can see there, the anecdotal evidence is something that really irritates people, but on and off, and every time I have seen, even senior most people, including me, sometimes, we talk about something, hey, I've seen this happen, we should do it this way or that way. Sometimes if there is no evidence, that is good, but by itself, I would consider that as very poor quality evidence to make a change in practice. What about systematic reviews? We are talking about it. I'll come to that later in this presentation. Most of the systematic reviews, if you've seen Cochrane base, you would find that it says no evidence of benefit. Does it mean that there is no benefit? No, it only means that the evidence for the benefit has not been collected adequately enough. And therefore, if a practice is making benefit in your setup, based on this statement, you should not change the practice. However, if you have evidence of no benefit or harm, that's a very strong reason to make a change in practice. So when you're reading evidence, you need to look at what exactly is the statement at the end, having gone through the whole paper. And do not be surprised if one population doesn't respond for the same reason that I have told you before. Going back. Because there are various reasons. I was recently at McMaster for a few weeks. I had gone for a sabbatical, and I met with some of the people and had some discussions with those people out there, and about these sort of things. And in the discussion, we identified a few things. One was that one of the reasons why that happens is because practice variation. Every place will have a different way of practicing things, even though it all looks like they're all doing the same thing. There is population difference, about which I have already talked. Individual patient characteristics, as I said, it's an aggregate response from the studies that has produced the evidence. You need to be aware of that. In fact, if you really want to get evidence for an individual, we need to go for what is called the precision medicine. It is coming. It is in its infancy at this point of time, but I have a feeling that in a few decades' time, it will be one of those things that we will be using regularly. And then, of course, the availability of resources and the culture. If you neonatal intensive care is a group of people doing work together, and if it's a hierarchical setting where the boss says everything and everything else, everybody has to follow, it often happens that the quality of care will suffer. And that is where the quality of care concepts are changing and moving to a collaborative approach. And that's something that the bundles of care is going to talk about. I'm going to talk about. Decision making. Let's move on to something called decision making is another concept. And you have the best evidence in front of you, but you can make mistakes unknowingly or knowingly, most of the time unknowingly, because of several reasons. And that has to be kept in the back of your mind. One of the things which is coming out now is what is the artificial intelligence. As I was preparing for this talk, I saw this news item that Watson Health and EBSCO has now joined together, and they have become an organization which is going to provide artificial intelligence for making decisions even better. But mind you, the artificial intelligence is actually borrowing data from research that people have done. And if it's a faulty research that they are going to use, then you're going to have a wrong decision. So you have to be very careful. This is for the youngsters in the group who would probably end up using this in the future. And, they have combined platforms and things like that. The other one is bias in decision making. A recent paper was Saposnik and group published this paper in the PMC Medical Informatics in 2016. They looked at all the various bias that people go through in decision making. And you wouldn't be surprised that there are lots of bias that comes into picture. Anchoring, availability. I don't have time to go through these biases as such, but be aware that every one of us is prone to bias. One of the things that I found very interesting is the overconfidence bias, which I'll talk in the next slide. So most of the things, the decision-making in diagnosis, but various other areas, and as well as treatment, people tend to have bias in the decision-making, and that can affect the outcome. This is what I was talking about, overconfidence and arrogance. Dunning and Kruger actually produced this graph and published the paper in the Journal of Personality and Social Psychology in 1999. Ever since, it has become part of many conferences that I have been going. People just put it up to show you that, there is the Dunning-Kruger effect in psychology is talking about a cognitive bias whereby people with limited wisdom or experience in a given intellectual or social domain greatly overestimate the knowledge or competence in that domain related to the objective criteria or to the performance of the peers or people in general. Now, wisdom, how do you get wisdom? You cannot get wisdom without experience. And I have seen this happen where, young consultants or young fellows come to the unit and, they feel like they know everything. Their skill levels are very high and, but they do make great mistakes. So this is something to be kept in the back of your mind. This has been applied in various fields such as business, politics, and in medicine. Moving on. Evidence-based practice. From evidence, I'm now moving to evidence-based practice. I have to introduce a legend, David Lawrence Sackett. Probably many of you have heard about him. I have made a valiant attempt to visit him and meet him, but unfortunately, I couldn't do that. Sackett is considered to be the father of evidence-based medicine. And he wrote this thing, that evidence-based medicine as a conscientious, explicit, and judicious use of current-based, the best evidence in making decisions about the care of individual patients. He also said it means integrating individual clinical expertise. So underline the word clinical expertise. That comes with wisdom. It takes a long time for you to develop a clinical expertise. And you need to, put that with the available evidence from systematic research seeming to be the highest quality evidence to really come out with a practice. And the bundles of care assure that the evidence-based care is delivered reliably. Neonatal environment is changing, and as Manoj has already in the introduction talked about it, quality improvement has taken over as one of the major activities at most neonatal practices. I was giving a talk, I think a year or two back, and the topic was recent advances in neonatal medicine, and I made a point to say that quality improvement is actually a recent advance in neonatal medicine, not only in neonatal medicine, all the fields of medicine. And yeah, moving on. How to practice evidence-based medicine. Fundamentals to learn and practice evidence-based medicine has been described in a recent BMJ publication, and that contains a lot of tools that you can use. I have no time to go through those tools, but just to point out a few important aspects. One is, you are probably aware of these two things: the pyramid of evidence. The highest quality of evidence you will get from systematic reviews, which also contains randomized controlled trials, and then editorials and expert opinions. As I said, expert opinions are some things when you have a hierarchical system that is often used as the evidence for a change of practice or practice itself. You've heard about grades, grade certainty ratings, and you need to really look at, when you're looking at literature or piece of evidence, what quality of evidence that is. Moving on, a little bit about systematic review. It is a detailed and comprehensive search strategy of published literature of clinical question. You are aware of Cochrane reviews. They are high quality systematic reviews most of the time, but there are other journals and other papers which are not related to Cochrane review, which can come out with good quality systematic reviews. What does it have? It defines the types of studies, included, excluded, including not only randomized controlled trials, but other type of trials is also taken into account when they are looking at it. They have a clearly defined explicit question they try to answer. They assess the quality of studies in a very careful manner. They have a very transparent, reproducible strategy for screening and including studies and excluding studies as well, and documentation of decisions. Indicates the type of interventions used and control groups in very clear terms. Discusses any bias and limitations which I was talking about, and actually includes meta-analysis. It's part and parcel of a systematic review often. So moving on to meta-analysis very briefly. It uses statistical techniques to synthesize the large amount of data from a systematic review into a single quantitative summary that are obtained in meta-analysis used to demonstrate the magnitude of effect. So it is more of a quantitative, quantitative assessment of studies as such, a group of studies, and especially when there is an intervention or two variables. The treatment effects of meta-analysis can be measured statistically. You are all probably aware of all of those things. I'm not going to go into details. A good meta-analysis should include reproducible data extraction, appropriate analysis and reporting of results, interpretation of findings that is supported statistically with data, implications for future research such as health policy or clinical practice. Moving on, implementation research very quickly. The goal of implementation research is to improve patient outcomes by identifying the effective ways of translating research findings to practice. This is a new area of research activity, just is evolving. One of the main purposes of health research is to optimize the healthcare by identifying effective healthcare interventions. Nevertheless, health research will only improve patient outcomes if the findings of research can be implemented into practice and appropriately implemented into practice. Improving the quality of care and increasing research-informed practice has received much interest over the past decade or so. Research-informed practice requires healthcare professionals to work and think differently. So there is a need for a behavioral change. because providing evidence is not alone sufficient. You need to put into practice. Sorry, just going backwards. So research has looked at how one might change the behavior of healthcare workers to facilitate the uptake of research. And that is where bundles of care comes into focus. So care bundles, moving to the main topic as such. Institute of Healthcare Improvement, you're probably aware of that. That is one which is leading all the quality care initiatives in various institutes all over the world. They are the ones who introduced the notion of care bundles. This is an independent organization, a group of well-meaning individuals, no-profit organization this is, who established this sometime in the early 90s with a headquarters in Cambridge, Massachusetts in USA, but they've got branches all over. I'm sure they do have a branch in India as well. Care bundles are a strategy developed by them to strengthen the quality of care and was introduced for the first time in 2001 in adult intensive care settings. And about 10, 11 years or so after having done that and having used it in many centers in North America, they would produce a white paper on it, looking at how it has produced benefits to improve health quality. And so it's moving too fast. Yeah. So their conclusion was the use of bundles of care intervention as an approach to improving the reliability of care received by patients and preventing certain serious clinical outcomes has been demonstrated successfully for nearly 10 years with a growing body of published results in medical journals. So yes, it's probably effective. It's very effective. What does it contain? It usually contains about 3 to 5, sometimes 6 interventions with strong clinical agreement. That's an important statement to make. Each bundle element should be relatively independent of each other. The bundle is used with a defined population in one location, like low birth weight babies in the neonatal intensive care unit. The multidisciplinary care team develops the bundle. Bundle element should be descriptive rather than prescriptive. And it should be a live document. You should be able to tinker with it, change it as things change in the setting. And we often do that. But more importantly, you need to have the real benefit from this one. You need to have 95% compliance. That means everyone in the unit, not just the consultants and the residents, but the nursing staff and paramedical staff and all the lab staff. Everybody has to be buying into this process. That is when you get the best benefit. And it has been shown over and over above that the moment the compliance lags or comes down, things starts changing again. Again, no time to go through this, but a paper in the International Journal of Quality Healthcare fairly recently have published how to go about it, the steps to be followed, which we follow when we produce a bundle in our setting. And they have given in the same thing in a chart form, which if you're interested, I can pass this on to you later. What is the evidence? Okay, we are all talking about it. There is a white paper which was produced by IHI, but what about an independent agency looking at it? So there was a very interesting paper which had reviewed and has presented as a journal club in my institution. This was the effect of care bundles on patient outcome, systematic review and meta-analysis. It comes from UK, Manchester Academic Health Centre in UK. The objective was to evaluate the effects of care bundles as tool for reducing the number of negative patient outcomes. They are to identify potentially effective approaches to implement it, to explore whether there are possible factors that modify the effects of care bundles. And the methods. They use PRISMA statement for reporting systematic review and meta-analysis. The eligibility criteria was they took all sorts of studies that have been published so far, conference abstracts, English language articles, and the participants for any age, but the paper had very few on newborn babies. And the intervention studies that evaluated care bundles, comparison with standard care, those settings where there was no care bundle, and number of negative patient outcomes fidelity, how much adherence was there to this one. And they analyzed using the standard methods of fidelity as well as the dichotomous outcomes, continuous data, means, and 95% confident. And they also looked at the heterogeneity, which I can talk about a little bit, maybe, which is indicated by the I-square. You must have seen on the forest plots that many meta-analysis shows. Will show you how low or how high the heterogeneity of this paper is. We would like to have very low heterogeneity. And so that's what would be a very high quality paper or high quality intervention or study. So what they did is they had 4 RCTs. Can you imagine? There were only 4 RCTs. There was a 2 cluster RCTs. I hope we know what cluster RCTs are. Cluster RCTs are when interventions in one unit is compared with standards in another unit. So the units are randomized rather than the babies or the individuals within the unit. There were 2 of them. And a large number of before and after studies. The duration of was nearly about 2.5 years. What did they find? If you look at it generally, you can see that the trend is for benefit. However, if you look at those RCTs ones, what they found is that it crosses the unity, and therefore it was not technically or statistically significant difference, but you can see how things are moving here. But taking all the other papers and publications together, large majority of nearly 120,000 participants, they found that the relative risk is 0.66, a significant difference it makes. And the risk of bias, however, varied, from low to high, serious, critical, using the grade that I talked about. Putting everything in together, what they did is they did some subgroup analysis as well, and they found that some of those bundles are very, very effective, others are not, using healthcare conditions, healthcare settings, various other elements, behavioral change, which is a very important part of bundles of care, and the compliance issues. Taking everything into account, we got a big diamond on the left of 1, saying that yes, it does make a difference. So there is evidence that it makes a difference. So all studies had high risk of bias and were low quality. Risk of bias varied from low, high, serious to critical. Before after studies predominant actually at this point of time. A center who was doing a standard practice now put into practice the care bundles, and they are trying to see how it made a difference. And there's a statistically significant difference in those papers if you were to take those things. However, RCTs, as I said, it didn't show a difference, although there was a trend. And they came out with this suggestion that future research should focus on improving the quality of papers, not necessarily the quality of the bundles that you're doing. And there should be transparent reporting. There were various strengths to this paper because the first and the only one of its kind. This was the first step towards identifying and addressing gaps in the care bundle outside the IHR settings. And the existing reviews have shown effectiveness in highly specialized situations like intensive care, but it is not generally generalizable. So individuals have to develop it in their own unit based on, I'll come to that later. Negative outcomes measures were studied, however, failed to identify any potentially effective approaches to implementation. And if you look at it, they didn't tease out the benefit effects, although they said that they want to look at it. And the behavior change technique, although they have done it, it was a retrospective data. Subgroup analysis was not mentioned before. So that's actually a negative for this. This could cause a bias as well. Moving on, literature on neonatal care bundles. How about neonatal care bundles? We haven't got many, to tell you frankly. Beyond case reviews and individual units, there are very few which has really looked at it in great detail so far. The use of infection prevention and care bundles has rapidly extended to neonatal care settings, no doubt about it. Sorry. Okay, moving on, I think I should. Some recent systematic reviews on care bundles and neonatal focus on evaluating the effectiveness of reducing simple line associated infections, of prevention of NICU in the low middle income countries as well. So these are some of the papers which have been published very recently. One very recently. There is a bit of an interference I can hear. I hope nobody is wanting to talk to me now. Okay, moving on. Most bundles are implemented in the tertiary care neonatal settings in most developed countries, but I think it's time that we move on to low some countries as well, and secondary level settings. So I'm moving on to the bundle that we developed, one of the bundles that we developed, and how we got about it at the Waikato Hospital, which I was the lead for this bundle. And the reason why we had to do it is because our NEC rates, after having been in our network of Australia and New Zealand, we were on the top unit for a long, long time. But come 2009, 2010, we moved to actually a better unit from where it was before. And to our utter surprise and disappointment, our rates started going up. I maintain a database of all the unit, and this is a run chart, and you can see how suddenly the NEC rates go up, and we didn't know why this is happening. We looked at our practice from various angles. We actually brought in an independent reviewer to look at it, and he couldn't come up with except saying that, hey, your unit probably has a lot of hierarchical approach. Your nurses are not being valued very well, which was a concern for me as well. I have brought this up many, many times, and we had to change that, and we have done that over the years, in the last few years now. And, if you look at it, we would like to have it less than this 5% range. So I got together with a group of people, nurse practitioners, other consultants, lab people, and infectious disease specialists. We got into a group, and we said, yes, we can do it. Let's go about it. We set up a task for everybody. Everybody looked at the literature, and we found one of the best literature. And this came from East of England Neonatal Network. My dear friend Nina Modi, I wrote to her and said, hey, I want to take some bits and pieces from yours and adapt it to our bundle. And she was very encouraging. Some of those things is shown here, what we took. Quickly going through individual aspects that I borrowed from there was oral immune therapy, which is nothing but using fresh human milk for mouth care alone, expressing breast milk, how to get more breast milk into the unit, standardized feeding regime. Drug dilutions was something that I got from another friend of mine, Dr. Suresh, in Singapore. He developed a bundle, so I borrowed it from him. So we started borrowing things from many people. And I shall not go through the details in the interest of time, but quickly going through, there are a few things that we had to address as well. The blood transfusion, we had a variable practice in the unit, so we changed it. We had a strict adherence to a threshold based on evidence. Dilutions, we were using a lot of supplements to our breast milk, which was increasing the osmolality, so we just worked on it. Antimicrobial stewardship, one of our workers, I got into a program called NAPS, which is looking at antibiotic use, and we tried to restrict the antibiotic use. And came along this ultrasound as a thing. We found out that we have an expert in our radiology department who is very good at looking at abdominal ultrasounds and picking up early signs of NIC. So we got him to do a 24-hour service for us. And we currently have a 24-hour service. Anytime we have a concern, we immediately call them. They come and look at it. The advantage of ultrasound is that it has got high specificity. It can rule out infection, but it cannot rule in NICU. However, it's very useful. Oral immunotherapy, I can't go through that. OIT, how to do it, we defined it in very great details, how to express breast milk, how to show the kids, and all sorts of things. Standardized feeding regime is one of the evidence which says that it makes a difference. So we put into practice as per the risks categorization, which we borrowed from the East of England document. We categorize all our infants less than, all our infants in the unit who are admitted immediately into 3 categories. And when the baby is admitted, we put a sticker there telling this red, we had a red, orange, and green sort of sign, indicating that, yes, this baby is at high risk, be careful. So everybody is aware of this. The nursing staff is constantly reminded. The resident staff is constantly reminded. Some more standardized feeding regime stuff. Drug dilutions. The most important thing that one has to keep in mind is, as per the Academy of Pediatrics from the American Academy, they have done some research work actually in the early 70s and 80s, and now it has become part of the protocol that you should not have an osmolarity more than 450 milliosmoles per kg for enteral fluids in a newborn baby, especially in a high-risk setup. Breast milk being about 300 or so. And finally, we produce a bundle, and it finally was put into practice. We have had many bundles and developed over the years. I started off with the CVL bundle, and as you can see, again, around about the same time, 2008, 2009, we don't know what went wrong. Things fell apart. We put the bundle in, immediately I got a reduction. And as you can see, it's slowly creeping up because staff has changed, the compliance rates are going down. So things are going backwards, and we are going to address this in coming ways. The IVH bundle has just been introduced. We are beginning to see some change. Neck bundle, which was introduced sometime in the mid 2016 or so. Again, the same problem, as I said, has shown some decrease. We have virtually eliminated surgical necks from my unit. In fact, there were some surgical trainees who came in here and they were lamenting that, we are not getting any training here because of this. They had to go to other units to learn neck surgery, surgical necks, and things like that. So in summary, neonatal environment is changing. Quality improvement has taken over as one of the major activities of most neonatal practices. Care bundles from one of the best quality initiatives to implement evidence-based care in neonatal settings like the neonatal intensive care. Care bundles work by evidence care is given, delivered reliably. It promotes awareness that the entire care team work together in a system designed for reliability. Bundles promote the use of continuous improvement methods to redesign care process through PDSS cycles. So it's important that there is a process, audit. In addition to the outcome audit, you have to keep on doing it just to make sure that things are all going as we have intended. And it helps refocus on a particular problem in a particular setting for a particular population. And it is definitely known to make improvement. It reduces variation in practice in complex settings. I should have had a slide here where the variation practice, according to Atul Gawande, the checklist man, he said that is the biggest bugbear in quality outcomes being low in settings where there is so much of variation. And the literature is building up on effectiveness of bundle of care practice, and I'm very sure that in the future we will see that this is the most effective way of putting evidence into practice in neonatal intensive care settings. And future should focus on improving the quality of the papers by explicit and transparent reporting. I think my time is up. So I will conclude here by thanking you for giving me an opportunity to speak. I'm ready to take some questions.
Wow, that is an excellent talk. Thank you, sir. Now, a lot of issues need to be resolved. Uh, I have the great pleasure to invite Dr. Geeta Gadwala and Dr. Prashant Karia. Both of them have been already introduced to this forum to moderate the panel discussion that is going to follow now. Over to you, Dr. Geeta and Dr. Prashant. I would request all of you to kindly type in your questions in the Q&A box, not in the chat box. Over to you.
Thank you so much, sir. It was really a wonderful presentation. So can I request you to stop your presentation so we can just...
Can I ask Manoj to unshare it, please?
Yeah, sir. You can just stop from the top. Yeah.
Is that fine?
Yeah, it's fine.
Yeah.
The beautiful thing which you said in the beginning was absence of evidence doesn't mean no evidence. So that was the one thing which everybody must learn. So over here, one of the doctor has just asked while you are talking about the IVH bundle. So how do we introduce it? What is the process? I mean, say for example, if in my unit, the number of cases of IVH are increased, then what are the things I should do? And by that, I can decrease the cases. So can you just say?
Yeah, there's a bundle. The evidence tells you that the process should start from in utero. So you have to get your obstetric colleagues and the midwifery staff in first and foremost. They need to put antenatal steroids in place before the baby is born, or at least get some time. That's one of the important things we have found. The second thing that evidence has been delayed cord clamping. It has to be practiced. It has shown that it reduces IVH, right? In our bundle, we have, developed a team approach. So we got a team standby always when there's an extremely low birth weight baby is being born. One consultant, one registrar, and a couple of nurses have to be there at the delivery. It's one of those things that we have put into practice. We make sure that the delivery room theater and delivery room are kept at least at 26 degrees. In India, that may not be a big problem. Maybe you may have to cool it down rather than heat it. But here in the Western world, that's one of the things. That theaters are kept very cold, and that's not good for the baby. And it is something that can, there are lots of evidences available. So we put everything into practice in bundle: minimal handling, golden hour. Within 1 hour, we have to put the lines, hands off after that. And so many things we have put into practice. In fact, in the last 2 years, we haven't seen any grade 3, grade 4 bleeds in our unit. It's just disappearing, So it is just not one single thing. There's so many things. In neonatal practice, that most of the diseases doesn't have a single silver bullet to solve the problem. So many steps have to be taken to get the best results.
Yeah, sir. So exactly what you said is a team. Together, everyone achieves more. That is what we believe. I mean, if we involve everybody, the obstetrician, the neonatologist, the nurses, then we can definitely decrease it. Yes, Geeta ma'am, the next question, please.
Yeah, there is another question here, which says, can the care bundle prepared by one unit or institution be used by another unit in totality, or does it require to be adapted to the local conditions?
Absolutely, it has to be adapted. East of England is no different from the unit that I am practicing. Indeed, yet we had to change so many things in this. So it has to be an individual unit, has to develop its own. They can borrow the principles from other places.
Yeah.
Any unit who would have put a bundle in would have done an extensive research, extensive literature search, and looked at all the evidences. So you can borrow those concepts, but you have to change depending upon your resources, depending upon your hierarchical or collaborative unit. There's a lot of things that you have to take. So no, it cannot.
Absolutely.
It cannot be.
Yeah.
Okay. Dr. Prashant, you can go with.
So, sir, the second question asked by Dr. Kedar is, in QI, we say improvement is 20% technical and 80% psychological. Now, what is your experience regarding behavioral or adaptive changes in QI, especially seen in bundle care approach involving many process changes?
A good question, really. Yeah. many people did ask me, in the early days when I was very enthusiastic, jumping around for the last 10 years, I've been in this business. They used to say, hey, I think it's all psychological, isn't it? Doesn't matter to me. You can call it as a Hawthorne effect. You know that what Hawthorne effect is. You think about a problem and you're trying to reduce it, automatically things starts reducing it. It's just all about focusing on a problem, identifying and focusing on a problem. That's why, I am interested to see whether, if you really look at it from a scientific point of view, is it's really making a difference? And it does. Is of all the quality initiatives that I have been involved or I've been reading about, evidence-based quality practice using bundles seems to be the most effective one that has been shown in quality practice. Yes. So even if it is, psychological, why not take it? It is making a change in your unit. Yeah. After all, it is the outcome which is important for you.
Okay. There is another question. This one is from Hilary White. And the question says, has your antimicrobial stewardship significantly reduced the time on antimicrobial therapy? And what is your empiric therapy for nosocomial infection? Do you use antibiotics in all births in case of early onset?
Yes. Yeah. Thanks for the question. Really, it was a revelation for me. Basically, we just went about routinely. We went about routinely, doing antibiotics, and when we set this up using the database that I have showed you, to our surprise, 90% of our babies were getting antibiotics prophylactically. And it just happened. We just didn't realize that this is happening in the unit, So unless you look at it, you won't find it. You think that, okay, everything is going well. Actually, basically, really what happened is when we moved to the new unit, we had a lot of pharmacy group and every, sort of people involved in the care. And it went off in a tangent away from what should have been happening. Lots of prophylactic antibiotics were being used. So our antibiotic stewardship looked at it and we tried to reduce it. We are in the process of coming down. We have come down to about 40% use now in the unit. And my aim is to get it down to at least about 30 or 20% using a criteria of sepsis scores and all the risks and things like that. It's a big task, but yes, we are doing pretty well, I would say. It's a big task, really.
Yeah, but the question, she also wants to know, what is your empiric therapy for nosocomial infection?
Oh, well, nosocomial infection, our empiric therapy, before we really get the cultures and stuff like that, we start with, in early onset sepsis, we are using amoxicillin and gentamicin as our first line, right? And for late onset sepsis, we start with flucloxacillin and amikacin. That's our drug of choice. And over the years, we haven't found any resistance to our antibiotics in the unit.
Okay, I would like to add to this. I think empiric antibiotic therapy in case of nosocomial infections would really depend upon what that particular unit is culturing. Absolutely. And what the sensitivity pattern is for the organisms being isolated.
That's right.
There just can't be one empiric therapy being practiced by one unit, which will be applicable to another unit.
Absolutely.
It really is unit specific. And I think for you to decide what you should use as empiric therapy in your unit, you should be maintaining a very good record of the cultures that you are getting, the sensitivities of the organisms being isolated, and then apply your mind to which are the ones which are working best for the organisms being isolated in your unit. And those should be the antibiotics that you use as empiric therapy in your unit. Obviously, once cultures come in and the sensitivity is there, then you will, review your empiric antibiotics. So I think that is the way to go.
Absolutely. You need to have a good microbiology department who's part and parcel of this. And that is part of an antimicrobial stewardship. It is the group from microbiology who are leading this for us.
Yeah, microbiology helps, but I think the neonatal unit, like in our unit, we just keep a record of all the cultures that we get positive, the antibiotics to which that particular organism is sensitive, and every 6 months we apply our mind to which organisms we isolated, which are the antibiotics that are working best or most frequently, they are working or sensitive, and we review our first line empiric therapy based on that information. That's totally on the neonatal unit. We do get information, like the cultures are done by the microbiology department. We do collaborate with them. We reach out to them in case we need help. But the data we are compiling on our own, because our microbiology department actually is compiling for the whole institute. And they don't really do it, area-wise.
Yeah. Simple things of medicine, are the things that you have to follow. These are the basic principles that you're talking about. Yes, you brought it out very well, indeed.
Nice, sir.
Okay, come to you.
Yeah, one more question asked by Professor Daniel sir. Yes, sir, you are talking about NEC bundle, the neck bundle. And he just want to ask, was it possible to identify the element, the intervention of the bundle that has the highest impact in your NEC bundle? There are so many, but which one is having more effect?
Oh no, we haven't teased it out actually, but I can say from my own impressions, but we haven't really teased it out. One of the things that we were really doing wrong was our dilutions. We were using a lot of complementary stuff into the breast milk, and that was really causing a problem. So that's one thing. And our ultrasound, we have got a very high quality ultrasound, which can pick up very quickly. And, so we have managed to really move from a high surgical neck unit to a zero surgical neck unit. And that's an impressive change that we have seen, but I'm sure, breast milk, talk about everything, everything comes into picture.
Okay, there is another question from Pinaki Chakravarti, and he wants to know if the midline position reduces IVH. You mentioned the IVH bundle.
Yeah.
What are the components of that bundle, Dr. Arun?
Oh, there's lots actually, and I know for a bundle we need about four to six evidence-based. But yeah, one of them is keeping the head in a midline position. There is a beautiful research done, actually nursing staff, it is published from Germany, I think, which looked at it, and they found that yes. So in our care bundle, we have initial stabilization bundle for IVH, which is in the delivery suite, getting the baby into keeping the head up position 30 degrees up, keeping the head in the completely central position. These are all followed in our, and there is evidence for that. That must have played a role because everything is a complementary benefit of everything that we do. So yes, we do practice that. I can send some of those bundles to people who are interested. I think Manoj will be able to give my email address to you, and you can ask people to And as I said, you have to develop your own stuff.
Yeah.
After having got something from me.
Thank you.
Yes, we do.
So one more question is from Dr. Thomas Joan. He says you have alluded to poorer outcomes with staff turnovers or a new staff. So in your unit, what do you do to help retain staff? In other words, you want to say a staff care bundle.
Why not? Yeah, staff care bundle. This is a new concept. Why not you have it? Yeah, people keep moving for various reasons, right? One of the biggest turnover is our resident staff who are coming in. They are trainees. They can't be there for long. They have to move on. You can't do anything about it. So what we do is any staff who's coming in, we have an induction program for the first, I think it goes on for a couple of weeks. They are not put into any action. They are they are buddied with somebody. They're learning everything. They're given a lot of bundles to look at, literature to study, and then there is a sort of cross-checking whether they have understood what it is going on. So it takes a while for those new people coming into the unit to get onto the practice. So we are trying to do that, really. Yeah. But, they would not have the same feeling. That's what I'm learning now. Like the original people who started the bundle, because it is something like your own baby that you're putting into place, and you're very happy, So that's something that you have to gain the trust as well. That's something that we are beginning to realize. We need to gain the trust of the people. It takes a long time. People have to buy into your project.
Yeah. Okay, Dr. Arun, another question. This one is from Dr. Kedar, and he wants to know how your team is addressing psychological or behavioral challenges in QI.
Well, I need to know what specific psychological behavioral issues are you talking about? Is it related to the bundle, meaning because you're putting the bundle, there is a psychological problem, or is it other stress and strains of the unit which are causing the problem? I need a clarification on that question. But yeah, if it is, but as such, I didn't find any problem with bundles, As I said, once people buy into it, it becomes your baby. You want it to succeed. So you're constantly trying to help each other and looking at it. In fact, I have every now and then somebody comes and tell you, I didn't see somebody washing the hands. Dr. Nair, can we address this issue? We don't pull them up in front of everybody, but then I go behind and then, go back and talk to them. Instead of in an insulting way, you should not do anything in the unit. You have to keep up the egos of the people. At the same time, you have to make a behavioral change. And, one of the slides missing from there is a theory of change, which I had put, I don't know, I just escaped from there. But the theory of change is a behavior has to be changed. Then only a change happens. You can't expect, somebody to come and say, hey, I'm seeing you doing this wrong thing. It is going to have a demoralizing effect for the whole unit. And we have realized that, the best way to address these things is not to point it out in front of everybody in the unit, take them aside, talk to them. And, they often come and they appreciate that, you have respected their independence or whatever. And, so yeah, it's an area of quite stressful area, isn't it? Neonatal intensive care unit. A lot of ego play a lot of role. You need to have a lot of we got social workers and we got emotional care support systems available for our staff as well to help them.
Great. Over to you, Prashant.
Sorry, I can't hear you, Prashant.
You got muted.
Yeah. So one more thing which can be added for a psychological or behavioral issues in an NICU or with a staff will be, you just listen to them, listen about the problems, ask what problems they are facing, and then you can give some solutions. But before giving a solutions, praise them for their good work they are doing for their tiny tots. Once they are being appreciated, they will feel important that yes, I'm doing something better, and then they will be doing a better work. So one more question is regarding the ELBW bundle. I mean, you had just mentioned ELBW bundle also. So Rajiv Malhotra is asking, there are so many issues which we have to monitor, especially in ELBWs, like detecting the perfusion, and we don't have a 24-hour functional echo or NIRS system over that. So how do we monitor? And choosing a right inotropes or vasopressor at the right time is also not easy. So how to deal with that?
Well. This is going beyond the scope of my presentation, this one. Yes, it is. Each one of those things, are important. Okay. But when you're talking about bundle of care, it is talking about a quality care in a broad way, rather than a specific way of how you will bring the BP up. You have had many presentations on this forum I have seen, where they have talked about all these things, which are the ideal ones. So take that evidence. There is evidence produced by people on what is the best inotrope to use in what settings. Put that into your bundle and use it for you. So that's what I would say. I don't want to deviate from this topic of quality outcome into, again, another topic of, what would you do for this sort of situation? But there are evidences. So this is all about looking for the best evidence and putting it into your practice.
Okay, I think we have no more questions now. Thank you, Dr. Arun.
Yeah.
It was very informative and I think very good learning. Thank you so much. Over to the hosts.
I have a great pleasure to thank all of you, the moderators who have done a marvelous job of summing up the questions and then finishing on time. Dr. Geeta Gatwala and Dr. Prashant Karia. Thank you so much, both of you. It is an honor to have you moderate the session. And Dr. Arun Nair, he is I realize that his work, his work is mostly not recognized, or he has done a lot of work which are actually not being known. This I know, and the way the depth in which he was talking, it is that speaks for himself. And thank you so much, sir. It was such a honor to have you. Keep you awake at 3 o'clock in the morning, because the New Zealand time and Indian time is different, and even though we have representation from all over the 47 countries, the majority are from India, so that is why we chose this time. So we have people who will be watching a lecture at different time zones in YouTube. So on behalf of every one of us, thank you so much, sir. It's such a huge honor. And before we close, I would like to express a great gratitude to all of you respected attendees who have been with us for now almost completing 2 years. We began in June 2020 with the first lecture by Professor Ola Sockstad, and now we are completing nearing our second anniversary with the grand final, the IAP Neocon in May. So thank you so much for joining us today. Please do join us for the next session that is going to be on the 28th of this month. That is by the true legend of neonatal ventilation, Professor Martin Keszler, who is going to talk to us about one of his favorite topics, one size doesn't fit all, the volume targeting concept and how it is applicable in various diseases. So it's going to be an exciting talk. I would invite all of you for that. That is going to be on 28th of April, again a Thursday at 7:30 p.m. Indian time. Until then, thank you. Good evening, good morning.
Thank you.
Thank you.
Bye-bye.
Bye-bye.